We'll move on to our next session, Hemophilia Comprehensive Rehabilitation Care. For this session, I would like to invite on stage the panelists, Dr. Sajia Gulsan, Consultant Hematologist at Peerless Hospital, and Dr. Probir Mondol, Consultant Physiatrist, MR Bangur Hospital. I'd like to invite on stage our speaker for this session, Dr. Prakas K, Consultant Hematologist and Professor, Department of Hematology, NRS Medical College and Hospital.
Good afternoon, everybody. At the outset, I'd like to thank the organizers for organizing this beautiful conference and having us here. It gives me immense pleasure to introduce the next speaker, Professor Prakas K. He was my teacher, and he has an extensive body of work on hemophilia. So the stage is all yours, sir.
So, very good afternoon. We can say it in two different ways. Look the matters in two different ways. Like one can say the hall is half empty, but I can say the hall is half full. So with that approach only, I will start. I was asked to make the presentation for 30 minutes. They have made it 13 minutes only. So don't take these 13 minutes as unlucky 13. Rather, we will try to make it lucky 13. And I think I am kabab mein haddi, because all the discussion since morning was surgery, orthopedics, related PMR, all those things. I am not a surgeon at all, but I deal with a disease, okay. So I deal with a disease which you not more often deal in your day-to-day practice, and that disease is hemophilia. It's a medical disease, but all the complications related to it are mostly musculoskeletal, if not some, in certain situations, some life-threatening bleeds. It can lead to CNS bleed, so it can be a neurosurgery situation like that. It can be GI bleed. In certain situations, we have to go for intensive GI management. It can bleed in the heart also, it can bleed in the lung also. So that way hemophilia is a disease which can manifest in each and every place in our body. And I have intentionally kept the rehabilitation part black, because I am really black about that part. I know bit about hemophilia, I know bit about comprehensive care in hemophilia. So I thought Dr. Pradeep would supplement me regarding that issue, but I have learned that he is not present in this hall right now. So still I am trying to highlight few points about that rehabilitation also. What is hemophilia? All we know, it's deficiency of factor 8 and 9. If it is deficient, then what happens? Patient bleeds, and if that bleeding continues, this thing happens. From today's point of view perspective, I am going straight away to that point. So there is recurrent bleed inside the joints. So if that recurrent bleed is there, patient finally will develop one condition that is called chronic synovitis related complications, arthropathy. So this is the background of the disease, X-linked disease. This is, anybody can recognize this gentle lady. They actually reigned our country, so that is the big clue, Queen Victoria. So she was carrier of this disease, but majority 99.9% in hemophilia are male, because it's a X-linked disease. So this is the scenario. Like many other diseases, hemophilia is also a disease which harbors 10% of the world patient pool, though it's a rare disease. Now the outlines I had made like that, like what are the different types of bleed, what are life-threatening conditions, what is the ideal time to go for factor therapy, steps to minimize deformity, because hemophilia is essentially related with deformities if untreated. So major joints, classic undergraduate teaching is like that, hemophilia bleeds in major joints. So I have shown the major joints where they most frequently bleeds. One of those joints, the scenario is like that due to chronic synovitis and there is chronic hemophilic arthropathy. This is the patient's both knee and that is the X-ray. So, joint hemorrhage, but it can bleed in muscles also, that is postgraduate teaching. Hemophilia can bleed in muscles also, deep-seated bleed, it can be superficial muscle bleed, deep-seated bleed. And if you look at the center point, that is the finger of a small child, only 10 years old, was worked up at SSKM hospital for almost 2-3 months, thinking it to be a case of JIA like that. So, finally, every test was normal and some of them the team had think about doing some coagulation test. Unfortunately, APDT very prolonged and then they referred to us, it was diagnosed as a factor 8 deficiency, hemophilia A. So, that was the only joint manifestation in a hemophilia A moderate. So, that can be muscle bleeds at different places, lacerations, abrasions, soft tissue hemorrhage. I am rapidly showing the picture. So, it can happen at any place, pelvic hematoma, psoas bleed. Finally, it cripples a people with hemophilia. We don't call them hemophiliacs. Earlier textbook they used to write hemophiliacs. That terminology is obsolete now. We call them PWH. So, finally, it is called a crippling disease. Now, coming to the life threatening bleeds, this is very frequently we see at our place, especially during the corona situation when there was no supply of factors in any of the hospitals in West Bengal. Many patients they came to us with this kind of CNS bleeds, ophthalmic bleed, it can permanently damage the vision, gluteal hematoma. When to reach the hospital or when to take the factor, because we know it is a deficiency of factor 8 or 9. So, essentially like diabetes you have to supplement by insulin or nowadays you have to go for oral hypoglycemic agents. So, here also we have a definite therapy, that is either factor 8 or factor 9, you have to replace that, and that concept is called factor replacement therapy or replacement therapy by CFC, means clotting factor concentrate. So, we have to replace that within 2 hours of bleed. Why these 2 hours? Because this 2 hours is called the regarded as the golden hour in hemophilia care. If you cannot push a dose of adequate dose of factor 8 or 9 within 2 hours of bleed, you can stop further bleed. At any point you can push the injection, but you cannot prevent these joint deformities. So, at the end of the year what happens, you are giving factors are very costly things, it is a very hemophilia care is a very costly therapy. So, if you don't push the factors within a specified time of 2 hours, then you cannot prevent joint deformities. So, that what happens, that is why it is called. So, to minimize this bleed, the goal we have fixed, acute bleed you have given factors, but you cannot prevent complications in terms of arthropathy. So, what should be done? How to achieve that goals? You have to go for price therapy. All of us we know, I am not going into details. Early therapy in terms of within 2 hours of factor replacement, and third you cannot read, I think. So, adequate dosing. Dose you are giving 400, 500, not that, it is a adequate dosing. We all must know what the actual dose. So, price is all of us do. I think this concept is already being discussed in several discussions since morning. In hemophilia, price P is protection. So, you have to protect the joint. If you allow the joint to move immediately after bleed, what will happen? There will be recurrent bleeds. So, due to recurrent bleeds, there will be accumulation of large volume of blood. So, finally, that will lead to chronic synovitis and hemophilic arthropathy. So, I am just briefly going for, yes, I am concerned about time, please do not remind me, I will finish. Wherever I will see the it is 0, I will stop, because there are a lot of things to discuss, I will stop. So, 10 years old male, past history of left psoas bleed twice earlier, now complaining of pain abdomen since last night. What do you think? So, that is the position of that child. So, now we have different gadgets in our hospital. At NRS we have a state of the art physiotherapy unit attached to our hemophilia care our department, and that was almost 34.5 lakhs instruments donated to us by an NGO in 2023, and we have a dedicated physiotherapist at our center who looks care of these patients. So we have this thing, that is what is called Prakas, point of care ultrasound. This machine is again gifted to us by one international agency. So we do Prakas, and you see, because previous history pain, so mostly what people think, we will give some painkillers like that and we will discharge that. But if you do Prakas, what is seen, those black areas, you see there is bleed within the previous. So this is the previous thing, within that those black areas, so there is fresh bleed. So you cannot manage this patient by only physiotherapy, you cannot manage this patient by only painkiller, you have to go for what? That is what is called police. So price is not sufficient for hemophilia care. Here the concept is police. What is that police? Police is optimal loading. You have to go for price. In addition, as because there is a fresh bleed, whenever some joint is deformed, whenever some muscle is already disturbed, there is more chance of recurrent bleed. So whenever there is a fresh complaint of a new complaint of pain, you think about a fresh bleed, you go for some optimal loading. If you can go for that, then you can stop that bleed. So that is yes sir, yes madam.
Sir, you have an extra 10 minutes, you need not hurry.
I am allowed extra 10 minutes. Okay, so pain relief, all we know, but that one should follow. In hemophilia care, no question of aspirin or any ASAID, that should not be. That is a very common mistake we often do. So treatment options in hemophilia are either you go for on-demand or episodic therapy, means patient has a fresh bleed and you go for replacement. But the gold or golden idea or the standard of care in hemophilia is prevention of bleeding. That is a concept prevalent in hemophilia care throughout the world. Unfortunately, country like us who cannot afford the cost of therapy with hemophilia, we cannot afford prophylaxis for all. But all the elite societies, I mean the affluent countries, they afford prophylaxis once the patient is diagnosed. So what will happen? Finally, I will show you some pictures. So advantages of prophylaxis are like that: less chance of bleed, less chance of synovial synovitis, so less chance of hemophilic arthropathy, and finally the child or the PWH can lead a normal life. So prophylaxis can be with different kinds of factors. I am not discussing those issues, only those who are dedicated with those kind of patients. So there are certain factors. One big thing about hemophilia is that we all know hemophilia is a disease or deficiency of factor 8 and factor 9, as thought of like diabetes. When diabetes was diagnosed, people thought about it could be treated with insulin only, but time came when insulin is going. So now many agents are there, we are treating with many agents which are actually not insulin. So the same concept is applied in hemophilia also. We are using some agents and mostly they are monoclonal agents. We are I mean monoclonal antibodies which are actually being used in hemophilia care nowadays. And the latest in invention is like this. This pen is coming very soon in India also, patient can carry. So it is made by the same company Novo Nordisk who have invented your insulin pen. So they have made already prepared this kind of pen, patient can take it, can carry it, it is stable in 30 degrees Celsius for 6 months. So it is that patient can carry that. So challenges in hemophilia care are big challenges. Patient may develop some antibodies against these factors. That is what is called inhibitors. I am taking the advantage of that, those extra minutes. Otherwise, I can stop. Okay. So more difficult to treat situation. Why more difficult to treat? Because hemophilia is a disease deficiency of factor 8 and 9. But if the patient is diagnosed with inhibitor, means has developed antibodies against inhibitor, you cannot treat with those factors will be of no use. Now we have some other options, and those options are these two. Either you have to treat with fever or Novo-7. If you by chance if you get a patient who is written by us, that patient is having hemophilia but with inhibitor, please don't give factors, because that factor will again aggravate the whole situation of inhibitor formation. That will increase the titer of inhibitors. So that will be a more difficult situation for us. So be careful about that. That's why I am showing this slide. So dealing with synovitis, next coming to that part, should always be assessed by a physiatrist or a physiotherapist, as because we have a dedicated physiotherapist. I have written that physiotherapist, but that should be done by ideally should be done by a physiatrist. So it can be investigated with any patient with joint pain, especially if the patient is having target joint. That is a concept in hemophilia care. We can go for clinical examination like HJH score. That HJH score is developed by CMC group, and Gilbert score. There are many others. We have lot of publications from our center on those issues, physiotherapy care, etc., etc. And ultrasound examination, we have already Prakas I have shown. With that same instrument, we can do color Doppler also. That mode we have in that particular instrument, we can see active fresh bleeding is there or not. So that is that much. So synovitis, all we know, this is that, and in MRI scan we can see the chronic joint with old joint. Sometimes there is confusion whether it is infection or bleed. So in bleed, usually we get black points in MRI. That is what is considered as hemosiderin deposition. So that's that. Implications, yes, rehabilitation programs, all you know, we have TENS, we have muscle electrostimulation, interferencia, all these machines we have in our hemophilia setup. So exercise, essential component, this is the manual we hand over to all of our hemophilia patients. We have made it. These drawings are done by hand drawn by our physiotherapist only. So different kinds of joints, different kinds of machines. So posture control exercise, that is very important in hemophilia care also. Not only the joint, particular joint, when one knee joint is affected and the patient is having some gait problem, all of you know that spinal, essentially the spine will be affected. So that spinal exercise and spinal care is very important. Surgery is one component in hemophilia. CMC Vellore, so far I know CMC Vellore regularly perform surgeries in hemophilia, especially joint surgeries and osteotomy kind of surgeries. Synovectomy can be surgical, non-surgical, by different kind of radioisotopes. Especially what I know, the CMC Vellore group, they use this yttrium 90, that radioisotope. So osteotomy, earlier very popular, not very popular in hemophilia care, at least nowadays. If somebody has real problem with a particular joint, the people favor total or partial, that is already discussed. That's that. But problem with, unlike other patients in hemophilia, the basic issue of that bleed is there, chance of bleed. So even if you supplement or go for 100% factor correction during the surgical phase, you may get bleed inside that. You have operated a patient, if there is fresh collection of huge amount of bleed due to disease per se, so and that is a very big issue, bleeding 35%, infection. It's from a published data, from international published data. Prosthesis aseptic loosening, that is, so because reduced bone mineral density is there, it is already there. Recurrent hemarthrosis and immune dysfunction, if it is associated with some 30% of the PWs who were earlier in 80s or 90s being treated with plasma derived factor, they get infected by HIV, hepatitis B and C. Fortunately, all the factors in market nowadays are recombinant factors, and those are devoid of any transmissible infections, TTIs. So this is the difference between they and us. All we know who are they, you can imagine, and these are the pictures from us. And why this kind of discussion in different forums? Because we want to change this. So we have, this is from our lab. So we have this kind of instrumentations. Reality, all we know, anybody can take it, download and can see. So what are the problems? Why these two different frames still prevalent? One is they and one is us, because of delayed diagnosis, inappropriate management, limited access to clotting factors, because factors are really very costly. I started hemophilia care in 2013-14 at NRS Medical College. That time only Medical College and NRS were the two facilities for hemophilia care, and with the repeated talk with the government officials, etc., now one thing has happened in hemophilia care in West Bengal, that 24 centers in West Bengal, they are working for hemophilia. Those thalassemia care units, they are also working for hemophilia. So now getting factors, it has become much easier. Patient from Baharampur, patient from Purulia need not travel to Kolkata to get factors twice in a week. So lack of awareness and education about hemophilia, about any disease, that is a very big issue. So goal in hemophilia care, rehabilitation, especially in hemophilia, nobody should die or become disabled when definite therapy is available. And this is comprehensive care. Can any of us imagine that all of these will be with us and we will go for? If I want to go for hemophilia care in my center, I will ask the medical superintendent or the principal, please give me all these, because this is I have taken from an international publication, they are doing this. It will never be possible. So forget about this nice picture. If anybody is interested to take care of those special group of patients, subset of patients, they just start alone. With that, I thank you. And before that, I have a academic promotion. I started from Bengal Society of Hematology as the founder, editor and chief of one journal, that is Journal of Hematology and Allied Sciences. 5th year we are running. Regularly we are publishing e and print form of this journal. Anybody interested to write anything related to blood disorders, always welcome. Not to contact with me, directly submit this paper. You just search this JHAS-BSH. JHAS means Journal of Hematology and Allied Sciences. -BSH means this is funded by Bengal Society of Hematology. So with that, I really thank you, and I am sorry for taking many more minutes.
Thank you, Professor Mandal, for elaborative discussion, and also congratulations for the publications. And now some time is there in our hand. 1 or 2 questions we can invite.
Thank you. Yes, sir.
Thank you, sir, for a nice presentation. I am Dr. Partha Mukherjee. I am heading the radiation oncology at Ruby Hospital. When I was a resident, I had a publication of giving radiation for hemarthrosis, those chronic bleeds, recurrent bleeds. And what I feel today is that since you brought up the topic of doing radiation synovectomy with yttrium-90, those are costly propositions. With the advent of targeted radiotherapy now, we can do a good job by giving external radiotherapy to those patients with precise mapping of the synovium, the synovial cavity, and that might bring in some good results. I have not done that personally myself now, but we did it when I was a resident, and at that time we had a good regression of the hemarthrosis and good functional mobility also at that time. So maybe we should look into that aspect, since you are at NRS Medical College and you have a very good radiation unit there. We can have a collaborative effort on this.
Thank you, sir. And I can comment only two, three things. One is these radioisotopes, they are primarily intended to be pushed inside the joint, and that will act for a long duration. And what sir is suggested, that is a very nice suggestion, and that we can use for a kind of palliative, because that may not give you a long term result. Immediate chronic synovitis, joint grossly affected, you may not go for, it's not possible to go for any surgical correction right at this point. So we have to go, we can go for that. Thank you, sir, for that good, very nice suggestion. If anybody, please.
Do we have any more questions? So that was a brilliant and very lucid presentation. We know how difficult it still remains treating a hemophilia patient as a team, and what difficulties we faced when we started the prophylaxis with pediatrics, in the pediatric age group, and then moving on to the adult age group.
Yeah, sorry to interrupt, because I am very happy to see chairperson who actually did DM, thesis on hemophilia under my guidance, and she dedicatedly started, we actually started the prophylaxis program in West Bengal in government setup. Earlier it was being practiced by ESI only. In government setup, prophylaxis for children we started, and that time no nurse was available, no extra staff was available. I basically compelled her to sit in the OPD at the end of the OPD and go for pushing those factors 30, 40, 50 children. Sometimes this happens.
Twice a week, every week I used to do that. There was
After
this tiny
the schedule OPD hours. But that way we started. Now it's a state program, and 24 centers in West Bengal, they are doing this program, running this program. It's basically now a national program. Thank you.
Thank you. Thank you, sir.